Thanks for coming out, everybody. My name is Jake Margulies. I recognize some of your faces. There's a couple faces that I might not have seen before. But thanks for coming out. Just going to present on infectious disease and contamination, sanitation, and waste disposal, which are chapters 24 and 25 in your book. There are a couple short chapters, so probably shouldn't take too long. This is a topic that you guys might know a little bit more about than I do. I didn't even know exactly what you did with the blades until today. Just some of the objectives. This is just from chapter 24 here, and you guys have those on your slides you can take a look at. Everything here came pretty much straight from the book. So pathogens are, and everything you see in red, things you might want to know for later. They were taken from the questions later on at the end of the chapter. So those are things that might be a good thing to kind of focus on in your studying. I think Carrie said that the exam's 100 questions.
120.
120. And it sounded like these two chapters are maybe like only 5 questions or so in the exam. So what's in red are from the end of the chapters, the review questions. So pathogens are microorganisms capable of producing disease. Examples are bacteria, viruses, fungus, parasites, prions. Bacteria are single-celled organisms, and they cause disease by they produce toxins that can interfere with the cell walls, eliciting an inflammatory response or invading host cells and messing with their machinery. So they can do it by multiple kind of actions. And examples of these are Staph aureus. An example of Staph aureus is MRSA. That's the one we're most concerned about of the staff group here in the hospital setting usually. Streptococcus pneumoniae, Clostridium difficile, and TB. And these are generally treated with antibiotics. Viruses are just, they're a lot more simple than bacteria. Bacteria have all the cell machinery. They're a functioning cell on their own. Viruses are just DNA or RNA surrounded by a protein lipid shell. So those need to invade a host cell to work. Examples of these are the flu, the herpes virus, which causes cold sores, chickenpox, shingles, HIV is another virus. And these can be treated with antiviral medications for viruses just like the flu. They're often not treated and just kind of let them run their course with supportive care. Other pathogens, fungus or molds, yeasts, mushrooms. Human infection in these is rare. They're usually only in immunocompromised people, which we do see a fair share of here. Parasites, protozoans, they're similar to yeast, really rare in the U.S. Mainly cause malaria, dysentery, hookworms, those kind of infections. And then prions, which are abnormal proteins, and those pretty much affect brain and neural tissue. Example of these are Creutzfeldt-Jakob disease, which is kind of the human version of mad cow disease. Prevention of infections. Healthcare-associated infections are a pretty serious issue. In 2002, there were 1.7 million healthcare-associated infections and 99,000 deaths. Healthcare-associated infections are infections that people develop in hospital and it came in without symptoms of it prior to admission. Most commonly, these are UTI, so we don't try to limit full use, fully care. Surgical site infection, Brucella, that's a pretty big one. We have the skip protocols where antibiotic needs to be in less than an hour, proper surgical site prep, amongst others. Pneumonia is another one, a bloodstream infection. The biggest ways to prevent all these, hand washing. For that we use antimicrobial, not sops, that should be soaps. And these help to dissolve the lipids and non-lipids, basically the top layer of our skin on our hands and anything that you might have on your hands, kind of wash away that bacteria on there. So soaps will just dissolve the lipids, but we have to use, in the hospital setting, antimicrobial soaps, which adds an extra layer to help kill the bacteria they have on their hands. For surgical site prep and IV site prep, there's a bunch of skin preps. One of those chlorhexidine, which destroys cell membranes of the bacteria. And that's how a lot of antibiotics work too, by destroying the cell membrane so they can't function. Chlorhexidine has excellent residual activity. Another red line there. It continues even after dish dry. It'll continue to inhibit bacteria for hours after application. We also use iodines, povidone iodine being one. Those also alter cell membranes and inhibit protein synthesis. For those to be effective, they must dry first. And those have some residual activity, not as much as the chlorhexidine. Precautions that we're going to take to prevent infections, standard universal precautions, which is basically just assuming that all body substances contain infectious material. And if you have any questions while we're going, feel free to stop me or anything you want to add. If I missed something, just jump right in. So hand hygiene, do it before, after touching a patient, contact with bodily fluids, and after removing gloves. Personal protective equipment that we use, obviously gloves. Anytime we're going to be touching bodily fluids, contaminated material, and non-intact skin. If you're just touching intact skin, it's not required that you wear gloves, but a lot of time we come in touch with those things anyway, so it's just a good idea to be wearing gloves. Gowns, when you anticipate that your skin or your clothes might come in contact with a patient. And definitely gowns when you're dealing with somebody that's on isolation precautions, and that's coming down the line in the next slide. Masks, eye protection when you anticipate any splashing might occur. So contact precautions, you want to wear your gown and gloves for contact precautions. And examples of why somebody would be on contact precautions, MRSA and C. diff. I bet you if they swab most of us here, we might have C. diff or not C. MRSA in our nose. But C. diff is one that I really would hate to get. Droplet precautions. You're using that for any time where infectious disease can be spread by in droplets, like aerosolized droplets. So the common cold, the flu are examples of those. They are much larger, kind of, their molecules, whatever the virus, whatever it is, doesn't quite go airborne. They stick in the droplets, so those will kind of fall. So it's usually within a few feet kind of the patient. So for that, you don't need to be wearing a PAPR mask or anything. It's just a regular surgical mask, gown and gloves, and then airborne precautions. Chickenpox, herpes zoster.
Dr. Rory Bauer, 0973.
Those are all things you can wear. The N95 mask, which they should probably do a fit test for you. I don't know if they do it yearly or every other year. Every institution's kind of different on how they do that. Respirator masks, I don't know if they have it here. And negative pressure for airborne precautions.
Dr. Bruce Israel, 9004.
So exposure to body fluid. Infectious body fluids are fluids that may contain hepatitis, HIV, amongst other infections. These are blood, semen, vaginal secretions, CSF, synovial fluid, pleural fluid, peritoneal fluid, pericardial fluid, amniotic fluid. And those are ones that you want to be concerned about. If you were having exposure to those, you definitely want to go for follow-up testing and go through the exposure protocol, whatever this institution has. Non-infectious bodily fluids are feces, urine, saliva, sputum, sweat, tears, vomit. These usually don't contain infectious materials unless there's blood present in those fluids. So for exposure, I'm sure mission hospitals have an exposure protocol. Well, number one is immediately you want to wash whatever site you get exposed to that. Wash if it's a needle stick site or an open cut, wash it with soap and water immediately. They say not to, that you don't necessarily need to try and like express, like if it's a needle stick, don't necessarily need to express it from it, you just want to give it a good scrub with soap and water. You immediately want to flush nose, eyes, mouth, skin with water, saline, irrigation. And then you want to report all this to a supervisor because mission has some sort of policy that will determine risk of exposure and what follow-up you might need. They'll also potentially draw some baseline laboratory testing from you and the patient with their consent to see if the patient was infected, one, and if you get a baseline for future testing of you as well. So the greatest risk for contracting infection from exposure are needle stick, mucous membrane, and then intact skin. Intact skin is pretty unlikely that you'll actually contract an infection. So yeah, the post-op exposure, like I said, screening, and then if you are high risk, they might start you on some prophylactic antibiotics, antiretroviral drills before even the lab results come back. So that was pretty much all of chapter 24 there. There's a few review questions at the end, which we can go over after. Here we're getting into chapter 25, which is the equipment contamination and sanitation and waste disposal. So some definitions from this chapter. Bioburden is the degree of microbial contamination, how much bacteria or microbes are on whatever's contaminated. Contamination is the presence of any unwanted material or pathogens. Cross-contamination is what we want to prevent. It's the transmission of pathogens from one patient to another, either by contaminated equipment, contaminated healthcare workers, or hands. So to avoid all this, we want to use decontamination, which is the process of cleaning, disinfection, sterilization. So those are all kind of different levels of decontamination. Cleaning, or sanitation. Cleaning is just the sanitation necessary before disinfection and sterilization is that first step of just kind of rinsing off all the whatever material you can see on something. Disinfection is by either using heat or chemical treatment. It doesn't kill all microbes or remove spores. It's pretty good. That would be like the purple wipes or I guess some of the other products we were talking about earlier. And then sterilization kills all microbes, including spores. And it's either done with steam, pressure, autoclave, dry heat, or chemical gases, and that will be done in sterile processing. So critical items, and this is the equipment that we use and how you want to clean it. Critical items are anything that contact with a break in the skin or a sterile body area. And these require sterilization at the highest level of cleaning. These would be surgical instruments, needles, catheters. Semi-critical items come in contact with mucous membranes, and these require disinfection. These are laryngoscope blades, LMAs if they're reusable, nasal airways if they're reusable. Most of the ones we use here are just one-time use. And non-critical items come in contact with intact skin, and these just require cleaning, except for if they came in contact with somebody who's on isolation precautions, then they require disinfection. So stethoscopes, beep cuffs, pulse ox, ECG wires, those all require cleaning after use, as well as the machine surfaces and everything. So disinfectants, there are several types. Alcohols are most often used on equipment surfaces. Chlorine, like bleach, used on floors and non-critical surfaces. Hydrogen peroxide can be used on equipment. Iodophores on skin and tissue, and that would be iodine contaminated. You can put it on iodine again. This aldehyde is used for high-level critical surfaces, fiber optic bronchoscopes, ventilator components, the inside of the ventilator. We use an aldehyde like that. And I'm not sure exactly what the specific cleaners that you guys use here, but I'm sure the protocols.
We don't use that anymore.
What's that?
We used to use, we don't use that anymore.
And there are a few others as well. Important to, wear gloves, use your PPE while you're using these so they can be teratogenic and cause cancer down the line. Anesthesia turnover with the machine. Chapter says to follow manufacturer's recommendations, I'm sure. The CO2 absorbers change those regularly. They have the dye and it changes colors. Is there like a certain time frame that you do here as well? Like
We do, weekly basis.
weekly? Okay. And then decontaminate machine surfaces. You don't need to do the inside of the machine and everything because we use.
After every case.
What's that?
We do it after every case.
The surfaces and everything.
On the surface.
Yeah. But like the inside of the machine, I'm sure there's some manufacturer they recommend however often that the inside of the machines get cleaned as well. But yeah, between cases we just do all the surfaces.
Right.
Breathing circuits, we use single-use circuits here. And another red one, single-use and bacterial filters are always indicated for known and suspected TB and prion disease. Multi-use circuits, which I have never used in my short experience. But those need if they were to ask you about it on the exam, those need a bacterial filter either between the endotracheal tube and white piece. And you need to change that filter between cases. Or if you had a filter between the expiratory valve and the expiratory limb, you need to change the filter and the circuit. On turnover, additional equipment, to decontaminate reusable equipment. These are all the pumps, BP cuffs, all that kind of stuff. Dispose of single-use equipment, and once again, refer to manufacturer's instructions. The workspace monitor surfaces contain the monitors, vent controls, flow meter knobs, vaporizer controls, blood warmers, machines, carts, drawer handles, BP cuffs, anything that could have touched the patient or us silly SRNAs could have gotten our gooey hands all over. I try and come in and do it, in the morning and throughout the day as well, to kind of touch as many surfaces that I'm touching as well. Clean them. Clean the surfaces that I'm touching. Consider all used equipment to be contaminated, and to kind of expedite turnover, it helps to have like a clean and a dirty area. Like if everything on the cart in the back is clean, everything on the machine is dirty, so when you guys walk in, you can just grab, machine, everything dirty. Toss, clean, whatever, everything on the cart, don't need to touch it. Just going back to that turnover, oh yeah, so continue on. In the operating room, we produce a lot of waste, about 20 to 30% of the total hospital waste. And disposing of all that is costly, so some places are starting to recycle, some places try and dispose of meds, trash, kind of to help cut down costs. Regulated medical waste, that's the RMW. It's biohazardous waste must be separate and labeled. So used blood tubing, contaminated gloves, syringes, soiled objects. I know here we just kind of throw everything in the same bag, so it's probably all just then. They don't separate anything out here, do we? For the most part. Drugs.
No, unless it's blood.
Yeah.
Adam Winters,
Blood
4947.
that out.
Adam Winters, 4947.
Drugs. If they're left out of the machine, they can be thrown out. There's the drug containers, as well, and then the sharps bins. Except for controlled medications, if one of us SRNAs were to leave a fentanyl syringe on the machine. I'm sure that's never happened.
Never.
We'd really appreciate it if you give it back to us so we can take it and waste it. But all the other medications, if they're on the machine and there's no patient, they're all out and get tossed in the drug bins. Sharps go in the sharps container. And then again, if one of us were supposedly to drop a sharp in the trash can by accident, you guys are helping us look for it. I'd never put my hands in there and dig around. Not really advised. So use some forceps to grab it. It's a much better idea. All right, that's pretty much everything from both of those chapters. There's some review questions in the back of each chapter. I don't know if anybody's had a chance to look at those yet or look at the chapters. That's pretty much what I had in red there, came to highlight what was going to be in those questions. They have explanations below them. I don't know, do you guys want to kind of go over that now or look at them?
Sure.
All right. And I meant to type them up so they'd just be in here, but I
So we can't look at the answers.
didn't get to it. Yeah, try to, here, I can read them out to you. What is the best definition of a pathogen? A microscopic organism that lives in mutual symbiosis with its host. B, any bacteria, virus, or fungus that is capable of living in the environment without any host. C, a microorganism capable of causing disease. Or D, human stem cells that can infect another human.
See.
Yeah. Question number 2, which skin preparation solution has the highest residual activity? A, chlorhexidine. All right. Which of the following are healthcare-related infections? Community-acquired pneumonia, anaphylaxis, contrast-induced nephropathy, central line-associated sepsis.
Sepsis.
Yep. What is the first step one should take after exposed to a needle stick?
Soap and water.
Yep.
Sop and water.
Make sure to stop well. Make sure to stop well. The following is a process that kills all bacterial life forms, including spores.
Sterilization.
Yep. The following is an example of a critical item, according to the Spalding classification system. Yep. IV catheter is a critical item. Laryngoscope blade is not, pulse oximeter is not, nasal airway is not. The use of special filters and single-use breathing circuits are always indicated in patients with TB and that prion disease. So that's really hard to know.
Yeah.
If people have prion disease, usually those are people that end up with like Alzheimer's and it goes undiagnosed a lot of times.
Plus, we don't know that much about prions.
Yeah, I don't
We've
know.
had a couple of cases lately that were do biopsy for
Yeah.
magic.
And you want to be really careful with those because there's no way of treating that. I mean, there's
Right.
nothing to do.
The equipment they use is, it's got a little sheet on it now, and staff use disposable.
Yeah, disposable everything. I mean,
Yeah.
wear gloves, full gamut. All used anesthesia equipment in the OR should be considered contaminated whether or not there is visible evidence of contamination.
True.
In patients with Hep C, in patients with prion disease,
In all patients.
in all patients. Yeah. So those are the questions at the end of the chapters. Anybody have any questions themselves or anything they'd like to add? Anything? All right then. Well, hope this was helpful for y'all.
Oh, of course.
Good to review, yes.
Thank you.
Yeah. Thanks, Scott.
Oh,
They are.
Yeah.
I'm Julia Parker. Have a minute.